Good morning, everyone, and thank you for joining us today for this Back to the Basics talk on how to assess the aorta. I have no disclosures. I will be talking about assessment of the aorta, and over the next 20 minutes, I've selected a few topics which we'll delve into in a bit more detail. We'll very quickly review the basics of aortic anatomy, then talk about the different imaging modalities available to us, with a focus largely on echo. Throughout this talk, we'll highlight some of the pros and cons of each modality, both for assessment of chronic and acute aortic conditions. And then we will close with a couple of case-based examples of some of those acute aortic syndromes. There are four parts of the thoracic aorta. Working from proximal to distal, there is the aortic root, which consists of the aortic valve annulus and cusps and the sinuses of Valsalva. Just beyond the sinuses of Valsalva is the sinotubular junction, which defines the start of the ascending aorta up to the brachiocephalic artery. The aortic arch is defined by the portion of the aorta from where these head and neck artery branch vessels arise. And lastly is the descending aorta, which begins just distal to the origin of the left subclavian artery and extends caudally through the thorax and abdomen. The most common imaging modalities that are used to visualize the aorta are echocardiography, both TTE and TEE, CT, and MRI. Transthoracic echo can generally provide good images of the aortic root and proximal abdominal aorta. The ascending aorta and aortic arch can be adequately imaged in most, with the descending thoracic aorta typically less well seen. The aortic root and proximal ascending aorta are best imaged in a standard left parasternal long axis view, shown in the top two clips, with a higher right-sided parasternal view sometimes proving more helpful for the more distal ascending aorta. The aortic arch and proximal descending thoracic aorta are best seen in the suprasternal view, shown in the bottom left. Aspects of the descending thoracic aorta can also be seen in the parasternal long axis, in modified apical views, and sometimes in paraspinal views from the back in patients with a left pleural effusion. The upper abdominal aorta is best seen subcostally, shown here in the bottom right. Transesophageal echocardiography has two main advantages over TTE: superior image quality and better visualization of the ascending and descending thoracic aorta due to their proximity to the probe in the esophagus. The ascending aorta is typically visualized in a modified esophageal long axis view around 100 to 120 degrees and can sometimes be seen from a deep transgastric view as well. The probe is rotated posteriorly to assess the descending aorta, which is much better seen on TEE than TTE, at 0 degrees for a short axis view and 90 degrees for the long axis. With further withdrawal of the probe, the aortic arch and ideally the branch vessels are seen, although this can be challenging with the potential for blind spots due to interposition of the trachea. CT has a number of advantages, including its availability, rapid acquisition and processing speed, and non-invasive nature compared to TEE. Importantly, it allows imaging of the entire aorta with a three-dimensional data set, which allows imaging of the lumen, wall, and periaortic regions, identification of anatomic variants, such as the common origin of the brachiocephalic and left common carotid arteries represented here in the left image with an asterisk, branch vessel involvement, and distinction among types of acute aortic syndromes. Oblique 2D imaging can lead to overestimation of aortic dimensions, which can be avoided with a 3D dataset. On the right is a markedly tortuous aorta with a thoracoabdominal aortic aneurysm, and a very obvious example of how the aortic dimensions would be overestimated in a standard axial slice shown in Figure C. By aligning the dataset perpendicular to the centerline or axis of the aorta, as shown in D, we can accurately measure proper aortic dimensions. The main downsides of CT relate to risks associated with the use of contrast, and it is the one modality with radiation, although there are a number of techniques to minimize the dose delivered. CT aortography can be used for chronic surveillance scans, with ECG gating being particularly helpful to avoid artifacts that can mimic dissection flaps. These are a few examples of potential artifacts. The image on the top demonstrates a pseudo-dissection of the ascending aorta with opposing linear artifacts due to motion. The image on the bottom demonstrates a double contour of the aortic root in a non-ECG gated study that may also simulate a dissection flap. In the setting of suspected acute aortic syndromes, a preceding non-contrast CT can be very helpful to rule out intramural hematoma, as we'll see in our second case later on, and an additional post-aortogram CT can improve the detection of visceral malperfusion in dissection and distinguish slow flow from thrombus in a false lumen. Each of these scans can be acquired in seconds. MRI provides good imaging of the aorta and surrounding structures as well as functional data, with the added advantage of no radiation. However, its limited availability, lack of portability, and longer scan times than CT generally restrict its use more to chronic surveillance in certain populations. When it comes to serial imaging and comparing findings between modalities, it's important to be aware of potential sources of error. Some include where the measurement was made. For example, was the measurement taken in the proximal ascending aorta or the distal ascending aorta? Was the measurement made from inner edge to inner edge of a structure or from leading edge to leading edge? And what was the trigger timing or phase in the cardiac cycle when the measurement was made? Despite differences in image acquisition methods and resolution, echo, CT, and MRI are all near equivalent as standards for assessing aortic root size, although much of the normative data and prognostic significance of aortic dilation is derived from echo. It is important to understand what we're measuring, though. This is a zoomed-in cross-sectional view of the aortic root at the sinus of Valsalva level, measured with inner edge to inner edge CT convention. One can measure from one commissure to the opposite sinus, shown here with the yellow line, and from one sinus to another sinus, which is often approximately 2 millimeters longer and shown here in red. Measurements using the sinus-to-sinus method will generally agree closely with echocardiographic measurements. The aortic root is very well seen on transthoracic echo and is measured in a zoomed-in peristernal long axis view as the largest diameter from the right sinus of Valsalva anteriorly to the posterior sinus, which is usually but not always the non-coronary sinus. It is measured at end diastole using the leading edge to leading edge technique. It is important to know that variations in probe angulation will cut the aortic root along different planes, and so it is important to actively search for the largest diameter. If the curvature of both sinuses is well seen and the line of aortic leaflet coaptation is midline, then this will likely represent the maximum obtainable measurement. One limitation of echo that is worth pointing out is that image acquisition is inherently operator dependent, which can introduce additional variability in aortic measurements. This study looked at the inter-observer variability in 60 patients, 20 with a bicuspid aortic valve, 20 with Turner syndrome, and 20 normal controls, with their aortic roots and ascending aortas scanned and measured by two different sonographers on the same day. In 1/4 of cases, there was a greater than 2 millimeter difference in the measured aortic root and ascending aorta dimensions, with larger discrepancies noted in patients with established aortic dilation. This can be attributable to a number of factors influencing test-retest variability, including different cutting planes, different measurement sites, and differences in measuring techniques. A difference of over 5 millimeters was seen in 3 patients. One example is shown here on the right, where the second observer has likely underestimated the ascending aorta dimension by measuring a side lobe artifact rather than the true posterior wall. The point I want to emphasize is that in cases of large differences suggesting growth, potential causes of test-retest variability should be considered before the measurement difference is felt to reflect a true change. In terms of defining normal aortic root dimensions, the figures at the top have appeared in guidelines for a while, coming from data published by the group led by Roman back in 1989. The charts at the bottom were published in the most recent guidelines on multimodality imaging of the thoracic aorta and are what I tend to use in our lab. These tables highlight the upper limit of normal, defined as 2 standard deviations greater than the mean predicted aortic root diameter, and are adjusted for age, sex, and BSA, which can account for changes in variables over time, helping to distinguish normal from pathological growth. While the aortic root has clear landmarks for measurements, the ascending and descending thoracic aorta do not. We know that the aorta gradually tapers as we move more distally, and so in order to make comparative measurements of a structure over time, it is important to specify the location of measurements by referencing them to a given landmark if possible. For the ascending aorta, this may be the distance from the sinotubular junction to the measurement, and for the descending aorta on TEE, this may be the distance that the probe is inserted from the teeth. We will now shift gears to talk about acute aortic syndromes. These are comprised of aortic dissections, intramural hematomas, and penetrating aortic ulcers. They are distinct entities but often present similarly and can be potentially life-threatening. The first case is that of a 51-year-old male with a past medical history of hypertension and unknown family history as he was adopted. He presented to a peripheral hospital with 2 months of progressive heart failure symptoms and on arrival described NYHA class 3 functional capacity. The physician there astutely noted his wide pulse pressure and loud diastolic murmur suggestive of aortic regurgitation. An echo demonstrated severe aortic regurgitation and severe ascending aorta dilation, and did also raise a question of a possible dissection flap, and he was transferred to our institution for further management. A transthoracic echo performed on arrival demonstrated a severely dilated left ventricle with mild systolic dysfunction. There was mild dilation of the aortic root and severe dilation of the ascending aorta, with an intimal flap visualized in the ascending aorta consistent with dissection. The aortic valve was trileaflet, and there was no pericardial effusion. On closer look, the intimal flap prolapses across the aortic valve during diastole, impeding valve closure, with resultant severe aortic regurgitation. The patient was taken emergently to the operating room where he underwent a valve-sparing aortic root replacement with TEE guidance. One TEE image is shown here, demonstrating the dissection flap with X-plane. Intraoperative TEE can be very helpful in these cases to help guide our surgeons in terms of aortic valve involvement and the extent of repair required. Aortic dissection occurs when there is a tear in the inner layer of the aorta which spreads to the medial layer, with resulting bleeding within and along the wall of the aorta leading to separation of the layers. Making the diagnosis in the acute setting is essential, as the risk of aortic rupture is high, typically occurring at a rate of approximately 1% per hour over the first 24 hours without emergent treatment. The classification of aortic dissection is important to help guide management, with common classification schemes including the DeBakey and Stanford classifications. The Stanford classification in particular is commonly used, as it separates dissections based on whether the ascending aorta is involved, as seen in these two examples of type A dissection on the left, or if the ascending aorta is spared, as shown in the type B dissection on the right. Surgery is recommended for type A dissections, whereas type B dissections can often be treated initially with aggressive medical management. Transthoracic echo can be of some value as the initial imaging modality, as shown in this first case. It is often the most easily accessible of the imaging modalities, has a sensitivity for type A dissection approaching 85%, and can help assess for complications associated with dissection. While a transthoracic echo can certainly be helpful if a dissection is identified, a negative study should prompt further imaging in the appropriate clinical context. For visualization of the dissection itself, we are looking for a mobile flap with motion that is independent of aortic wall motion and ideally seen in multiple views, helping to distinguish it from reverberation artifact. If possible, it is important to describe which aspects of the aorta are involved and visualize the entry and exit tears. The true lumen, which tends to be smaller than the false lumen, will expand in systole, whereas the false lumen diameter often increases in diastole. The true lumen exhibits forward flow in systole with no spontaneous contrast being present, whereas the false lumen may show evidence of spontaneous contrast or even thrombus formation. In making a diagnosis of aortic dissection, it's also important to look for the company it keeps. Aortic dilation is the biggest risk factor for aortic dissection. Concomitant aortic regurgitation can be seen due to a number of mechanisms, including aortic root dilation, cusp prolapse, flail leaflet due to disruption of the annular support, prolapse of the flap across the aortic valve as shown in case 1, or due to pre-existing aortic valve disease such as a bicuspid aortic valve. A dissection which extends to involve the pericardium can result in a hemorrhagic effusion and tamponade, and a dissection flap abutting the ostium of a coronary artery and obstructing flow can lead to myocardial ischemia and regional wall motion abnormalities. CT is typically considered a first-line imaging modality for the diagnosis of aortic dissection. When considering the ubiquitous presence of CT scanners in most hospitals and speed of image acquisition, CT is generally considered to have the quickest diagnostic time. High-quality images can be acquired in an operator-independent fashion, unlike echo, and its diagnostic accuracy approaches 100%. Here we very clearly see a dissection flap in the aortic arch, an area that may be suboptimally visualized with echo. MRI, while also highly accurate and with the added advantage of radiation avoidance, has a number of limitations in the acute setting which limit its use as a first-line modality. It is generally less available than CT, and the longer acquisition times, coupled with greater challenges in managing patients in an MRI scanning area, make it a less than ideal test for unstable patients. Here we can see an aortic dissection involving the ascending aorta in the top image, with the white arrow indicating a tear site, and the aortic arch in the bottom image. Case 2 involves a 78-year-old gentleman who had an out-of-hospital cardiac arrest and was found to be in PEA, or pulseless electrical activity, when paramedics arrived. He was resuscitated, and the decision was made to bring him to the cath lab, where coronary angiography demonstrated a 95% stenosis of his right coronary artery, which was treated with a drug-eluting stent. He was transferred to the intensive cardiac care unit, where he surprisingly remained in refractory shock with ongoing significant vasopressor requirements, suggesting that perhaps something else was going on. On repeat blood work a few hours later, his hemoglobin had dropped significantly, and a chest x-ray performed suggested a widened mediastinum. A bedside focused echo confirmed that his LV function was in fact hyperdynamic. He was felt to be too unstable to go for CT scan overnight, and so a TEE was performed. Views of the aortic valve were challenging, but the valve appeared to be congenitally abnormal and severely stenotic, and the ascending aorta was severely dilated. Esophageal views of the descending thoracic aorta demonstrate crescentic thickening of the aortic wall at the top of the images, consistent with intramural hematoma. The patient did go for CT scan the next day, with some selected images shown on this slide. In the top left, if you look closely, the pre-contrast unenhanced scan demonstrates a circumferential thickening of the aortic wall with a higher tissue density than the intraluminal blood, which is a classic finding in intramural hematoma. The corresponding contrast image is shown in the top right, where the circumferential thickening is again noted with preservation of the lumen itself. Looking at the descending aorta shown in the bottom image, one can again appreciate thickening of the aortic wall, which extends throughout the entire descending thoracic aorta. Intramural hematoma encompasses somewhere between 10 and 25% of acute aortic syndromes, and is thought to result from hemorrhage of the vessels within the medial layer of the aorta or microscopic tears in the intima. Unlike aortic dissection, there is no dissection flap noted, nor any obvious intimal tear or re-entry site. Over time, intramural hematoma can regress, persist, lead to aneurysm formation, or progress to dissection. The imaging diagnosis of intramural hematoma is based on identification of fresh thrombus in the aortic wall. It is characterized by crescentic or circular thickening with preservation of the smooth aortic lumen wall, which differentiates it from the irregular intraluminal surface of aortic atherosclerosis. The tissue density is higher than that of unenhanced blood, around 40 to 70 Hounsfield units, which relates to the presence of concentrated hemoglobin in recently extravasated blood. It does not enhance with contrast, and often the central displacement of intimal aortic calcification, as shown again here from this case, can provide additional support that the thickening noted lies within the aortic wall rather than representing intraluminal thrombus. These findings are most evident on CT and are what makes CT the typical first-line imaging modality for intramural hematoma. If CT or TEE findings are equivocal, MRI can be helpful. To sum things up from a modality selection perspective, for chronic surveillance, if we are evaluating a structure which is readily visualized on transthoracic echo, such as the aortic root or proximal ascending aorta, then it's an excellent, readily available modality to choose. Of course, there are parts of the aorta that are not well seen with TTE, and if we're interested in imaging the entire aorta, or those specific aspects not well seen with TTE, then CT is an excellent alternative. MRI may in fact be an even better option as long as it's available, particularly if serial repeat examinations are being considered in a younger individual, as it does not have the associated radiation risk which accompanies CT. When it comes to the diagnosis of acute aortic syndromes, while the advantage of each modality must still be considered, we place an even greater weight on the diagnostic performance of these tests, as making an accurate diagnosis of a potentially life-threatening condition is paramount. CT and MRI have the highest sensitivity and specificity for detection of all acute aortic syndromes, but the quick diagnostic time of CT in the acute setting is what makes it the usual first-line choice. In patients who are unstable and a diagnosis is required at the bedside, transesophageal echo is a very good option. Similarly, transthoracic echo can be performed at the bedside and is perhaps the best modality for diagnosis of complications of acute aortic syndromes, such as aortic regurgitation or pericardial effusion, but its limited ability to visualize the entire aorta often makes it more of a complementary tool. The take-home messages include the fact that we have multiple modalities available to assess the aorta, and it is important to consider the pros and cons of each, along with patient-related factors and institutional capabilities to help choose an appropriate test. For quality assurance within an echo lab, particularly when making comparative measurements of a structure over time, it is important that sonographers follow standardized recommendations for image optimization, acquisition, and measurements. For the aortic root, for example, that means trying to find a plane which maximizes the aortic root diameter, and measuring using the leading edge to leading edge convention. For interpreting positions, it is important to try and standardize definitions of what is normal versus abnormal, including indexing measurements for factors such as age, sex, and BSA. And it's important to directly compare images between studies to determine if any measurement differences reflect a true change. For chronic surveillance of the aorta, TTE is appropriate for serial assessment of the aortic root and/or the proximal ascending aorta, with CT or MRI being the modalities of choice for visualization of the entire aorta, Lastly, in the setting of a suspected acute aortic syndrome, CT is typically the first-line test, with other modalities providing complementary information. Thank you.